Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair at Appeal Academy and creator of Top Gun Audit School. And we are live on the February 19th, 2016 edition of Finally Friday. And I do want to, as usual, thank you for spending your precious time with us here on Finally Friday. Today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide. Also by Recovery Analytics, that's my co-host Sharon Easterling's company, committed to your success. We are also now sponsored by MedLinks Cost Containment, makers of the Healthcare Audit Tracker. Visit ZeroDenials.com today to see how they can help you track audits and greatly reduce or even eliminate denials. Another sponsor is Aerolib Healthcare Solutions by Dr. Deepak Pahuja. They have a patient-centered total quality management consulting firm, and they are the makers of the Physician Advisor's Guide DVD, which is also available on demand. And finally, we are sponsored by the Council for Certification of Medical Auditors, the CCMA. They are the creators of the widely used Certified Medical Audit Specialist certification, or known as CMAS. Anyway, thanks for being with us today. We are going to talk about the nightmare that now inhabits the lives of anybody in a provider facility and involved in revenue cycle or revenue integrity. The challenges keep growing, and they are truly horrific. So this week, we're going to kind of set the stage for what we're going to be doing over the next couple of months. And we're going to be doing our best on forthcoming shows to point out to you the direction of reliable and effective solutions. And I say reliable and effective because my career, half my career, I spent in production and manufacturing and the study of what makes businesses work well and what not. And reliability and effectiveness are the two big things. Reliability meaning the kind of things that you do or don't do that should be done in order to positively affect the throughput of whatever it is that you do. And effectiveness is about whatever you do or do not do, things that have a positive effect on throughput. That's what I mean. So that's why we focus on that. It's true in every business, whether you're in a hospital or a hot dog stand. So that's what we talk about. Okay, so I also have on hand my loyal and faithful and reliable and effective co-host, Sharon Easterling, who's an auditor, speaker, and appeal writer and the owner of Revenue Analytics. And also my other co-host, Bill Mom. He's a practicing clinician, a speaker, and a certified medical auditor. He also has his own company. And Bill, all of a sudden I didn't put it in my, what's the name of your company? Your
Health Revenue Integrity.
Health Revenue Integrity, right. HRI. I got to add you to the list. Okay, anyway, before we get started, I want to switch over to the website. And for those of you who might be new to using the room that we're in, I want to tell you that if you go to the website, appealacademy.com, scroll down anywhere on any page and you find this box. If you click on that, it opens a page that then gives you all of the instructions on how to use the control panel that is on your screen. It's that black box with the green buttons that's at the top of your screen when you get in our room. It shows you a couple ways to get the audio in case you want to do it differently. It shows you how to find the chat box, and I highly recommend you open that and join us in the chat room. That is not recorded or saved anywhere. I mean, sometimes I copy the email addresses people put in there for things, but other than that, it's not recorded. That's nothing that will ever be discoverable. So you can speak freely in there. Of course, however, please keep it professional. We have a lot of different kinds of people on here with different jobs and everything. I don't want to get personal. Anyway, the other thing is you can zoom in and out of the screen if I'm not zoomed in enough on something for you. You also have the participants list where you can, if you point, you're at the top of the list. If you point at you, it will give you a little dialog box that will pop up next to it and let you change your name. You can put first name, last name. I don't care what you put. You don't have to do that either. But that way we might be able to talk specifically with you in the chat box. or you with somebody else. Anyway, forget it. There are control options, but I'm not going to give you control of the room, so forget that. Anyway, okay, that's enough about the controls. And as I said, we are, if you've come here, you probably already know about the This Week on Finally Friday page, which is where we put things every week. I usually don't update it until like Thursday, and sometimes on Friday morning, because I'm just trying to put together the show and get it all set, and it just doesn't get done before Friday morning sometimes. But anyway, this is where you get the handouts. And usually there's a link like this that if you click on it, it takes you straight down the page to the box where you can get the handouts. You just put in your email. It doesn't necessarily add you to any of my lists or any email lists or anything. And it should take you then directly to either a PDF of the slides or a zip file if we have more than the slides that week. If you have trouble getting the handouts, just let me know in the chat box. I'd be happy to then send them to you, or somebody else may send them to you if you mention it in the chat box. Everybody's kind of helpful that way. So, and then after the show, you can come back to this page, and usually by Saturday at least, I get the link to the replay. I'm using this, it's kind of a strange format. It's called a WebM format, but that's how they come to me. I get those pretty quickly. And if you can't watch it in your browser, you can download the Real Player for free. That's what it's called, the Real Player. There's the link to where you can get it. And that will let you download, the link will let you download the video, and then you can watch it with the Real Player. So if your browser won't play it back. Okay, enough of all the housekeeping. Let me get back to the show. Here we go. Okay. Last week on Finally Friday, we were talking about predictive analytics, and we had the guys from Zermed here to help us understand what the value of using predictive analytics was, and especially being able to take advantage of algorithms. And we talked about that a lot Friday. I'm not going to go over that here, but that was last week's, and you can see that in our archives and go look at last week's if you didn't get a chance to do it. This week we are talking about the evolving landscape, the nightmare that has become revenue cycle, because it has become so complex, and there's so many things that are affecting how you do your job and how your hospital can get paid or not get paid. Some of the things that Bill and I were talking about yesterday, Bill and Sharon and I are talking about is, these 5 things. There's the complexity of ICD-10. We're not really going to get into that today, and we're not going to get into the ACOs, but those are both big deals, right? Because ACOs, who knows how that's going to really work out? Who's going to get paid what and who gets to decide? That's a complexity. It's CMS trying to push the complexity down the line to somebody else, so they don't have to play with it so much or try and handle it so much, although they'll still be very much involved. Then there's all the bundling and the pay-per, value-based payment programs that are coming out, and of course those are coming at us very fast. And at the same time, there's all the payers are coming up with their own specific rules, and that is getting more and more specific, more and more troublesome, as all of you know. And the question is, what can we do about these? And then there's this one that Bill brought up to me recently, and I hadn't thought much about it, but I started reading up, finding out that all these high deductible health plans are causing problems for providers, and so we're gonna talk about that. All of it is because everything has become very complex. And you begin to wonder why. You start to wonder about, why do you really need a blender with all those? Come on. Tell me honestly, do you use all those different buttons on your blender? I'd be happy with one button. I just want it to come on. I want it to blend. I don't need all those other ones. They don't really look that different to me anyway when I turn them on. I sure don't notice any different. Passwords are even ridiculously complex now. Okay, you can't just assign a password. You can't give a password to anything you want. Now you have to do it according to these systems that tell you, well, you got to do this, you got to do. it's bad enough that you have to have so many passwords, but now they've got to be this complex. Who the heck can remember all that, right? And then there's, things like even remote controls. I mean, Apple makes them really simple, but that's sort of the way Apple operates. And yet, the older TV remotes, I mean, they got so many buttons. Every time you look at one, you got to hunt for what it is you're doing. Apple makes it a lot simpler. Why can't everybody do it that way? And then there's, I'm always reminded of this quote from Albert Einstein: if you can't explain something simply, then you don't understand it. And I feel that's, who can't agree with that? I mean, if you can't explain something, then do you really understand it? You can't, prove it. You can explain it or not. And you ought to be able to explain it simply. Now, I'm not talking about things like quantum theory. Okay, nobody can ask a Nobel Prize laureate to explain how they got a Nobel Prize in 25 words or less. But they do have ways, the best ones are the ones who can explain to a layman, what it is that they work on. And they actually do work on doing things. It's like Einstein. He spent all that time coming up with E equals mc squared, a 1-inch formula that explains some very complex things. Takes a lot of work to get there. And that's what we really want, because complexity is not helpful, okay? There's like this, you've probably seen a diagram like this, and we all know from experience, it's like telephone, right? Here's what somebody's looking to get, or that's what they asked for. And somebody who analyzed what they asked for, they see it differently. And then it goes into the design phase, and it comes out quite different, probably not useful. And then there's, you give it to the production people, and they start working on it, and it comes out different again. And then what the user really wanted was something very simple like that. And then what they wind up with is something that kind of works strange. And I know this to be true. From like half my career I spent in production and manufacturing, and I designed business systems and production lines. And I always knew that by the time it got to the production floor, it was going to be probably 50% of the quality and value of what I originally had designed. And that's because a lot of other people get involved, and it's hard to keep it, simple because people want to make things complex. So let's talk about some things that were in the news this week that I think kind of make the point that complexity is, it's getting the better of all of us. It's bad enough that meaningless use is, meaningful use is really kind of meaningless. I don't understand the criteria that they came up with. I see them, and there's a lot of things that I don't understand why that's even important. I guess it is. But now even CMS has, we talked about it on a show before where Andrew Slavitt from CMS, he's one of isn't he an associate director or an acting director? He was saying that meaningless use has become it's too tough. It's too hard to use. Physicians shouldn't have to do that. And so they're going to get rid of it. He said it was basically dead. But that was he misspoke, because really it's not dead yet. So there's been a lot of things coming out that say, oh, you think it's dead, but you still got to use it for now. And supposedly there's something better coming. Remains to be seen if it's better or not. I kind of doubt that it is. And this is an article that was in the Journal of AHIMA this week talking about it, and you can see that link on the slides. And then there's this, which talks about information governance. I even had to go look up what the heck information governance is, what IG is. There were a lot of articles I found about IG, and none of them said what IG was, so it took me a while to figure out what it was. Basically, it's just handling your data. And so here is a whole bunch of benefits they're giving about, why you should train your workforce now to deal with information governance. This goes beyond, what's called big data. This is about, trying to get everybody to recognize what the value of it is. If you go to this article, there are some links to some decent articles that are about, well, how are you going to deal with this? So it's in that original article. You might want to go take a look at that if you are involved in trying to get people to understand what information governance is and why it's becoming important, or if you want to know why it's becoming important, you want to follow articles like that.
Governance, Ernie, it's that's one component of it. Definitely being able to manage the data, but it involves lots of other things as well. I talk sometimes about the horse coming, the cart before the horse. And as we implemented the EHR, and as we developed new processes, we didn't necessarily keep a handle on what information was going in, who owns that information, what are the regs and the rules around that information. So we started adding all these new things, and we forgot about, we used to have a medical record committee. Well, I remember that. We used to have a forms committee, and that forms committee used to decide what forms we were going to have in the chart, and I knew that if it had anything to do with a vent, I needed to go to respiratory. They own that. They own that care plan for that. So that's part of information governance. Making sure we know what templates are set up in our system. And if we do have those templates set up, who owns those templates? What is the, quote, effective date and, quote, end date for that template? Or when does it need to be revised? When does it need to be updated?
Yes.
Even a simple field within a record. Well, Dr. Smith wanted this field. Well, why did he want that? What's the vetting process around that field? Do we vet information that we put into our EHR, or do we just take on whatever anybody wants? What's the process of that decision making? So information governance is very important. I think a lot of this used to lie within the HIM department, and as we implemented EHRs, that kind of mingled out. We have our CIOs that are kind of handling that, but there are mechanics around it. Let's talk about Joint Commission here for a second. Joint Commission requires that you have an H&P and a discharge summary for every patient, and their time frames around that. Are we complying with that within our EHR? Do we have Joint Commission next week? Are we going to be able to attest to our policy? Is it comparable to the policy and procedure of the rules and regs of our medical staff bylaws? So it's very complex, and I find it very interesting. I've kind of been on board with it, so I could talk about it all day. But that just kind of gives you a feel for what information governance is and how we need to get some control back on those particular things. I would suggest that your facility, if you have not looked into having an information governance officer, you might want to do that, because this will be the next big thing after, how we had privacy officers and we had our chief compliance officers. Well, we're about to have information governance officers too.
Yeah, it's a total.
Sharon's right. Sharon's completely right. I mean, the healthcare industry as a whole is changing so quickly that it's not just governance of what we're putting in, but it's governance what needs to come out. So I see in systems, we built a work queue 3 years ago. Well, that's no longer current. But people keep working it because that's what they do. Accountability has been the biggest loser in this EHR component, because we used to have accountability of records, medical records committees, physician committees. There used to be accountability all the way through the record. And if somebody missed it, it was traceable. You could go back. You could do your education. A lot of that is being lost, and the difficulty in getting data back out and the difficulty in holding somebody accountable for all of these fragments, because EHRs actually kind of fragment your process into little bite-sized pieces. And those fragments have to fit together like a stained glass window. And if it doesn't, you just have a broken window. So I think that Sharon's completely right that information governance, it isn't on the horizon. It's here now.
Yes, right. That's the trick, and it's again, like Sharon said, we've wound up with the cart before the horse. It was like the EMR was mandated. And yes, you've been given money to put it in, but it's so difficult to create because there was never really one on paper before. It was different everywhere. And the trouble was that requirement of what was on paper. You may have that. You may have a system that was pretty good in your facility before you got the EMR, but it's needed to change to fit the requirements that the industry is demanding now. And so that's why the EMRs don't fit. That's why these processes that, like Bill said, you created one 3 years ago. Well, but it's obsolete because the things keep changing. Here's somebody saying in the chat box, how timely is this discussion? We're having issues with parts of the medical record that in the EMR is being placed in a data warehouse where very few people have access to it. And there's a big problem with orders. Yeah, that's exactly what Sharon and Bill were just saying. There's an awful lot of data going in, but what do you do with it? How do you get it out? What needs to come out? What needs to stay there? Who needs to have access to it and who doesn't?
Well,
so
and
all
the
those
validity
things
of it, Ernie, too. I mean, the validity of that data. Where's that data actually pulling from, and what is the end product interpretation of definition of that?
Right.
I have a friend. They had this database that they had their team using, and everyone had a different understanding for what that field meant. But everybody was working it, and everybody was picking something. But we don't know. They didn't even define it. So they didn't understand what they were picking. But guess what? We learned all these wonderful reports off of them, and we sent it to this hospital, and this is what we're showing them. Well, you never defined it. You're not really showing us anything. Go ahead, Bill.
And I do a lot of auditing and end up with root causes, and I have seen repeatedly where it's an IT solution to a perceived issue. For example, inpatient orders. Oh, well, the 2 midnight rule, what we'll do is if they're in this accommodation code, which is really a bed type, then we're going to get this doctor's order and we're going to assign an attestation to it. So you see these things that are disjointed when you audit it, and it's real easy to see that this is a system-generated event, may not even be realistic. Worse yet, there are some systems out there, and I'm not going to mention them, but there's some systems out there where the accommodation code actually drives things. And so if you want to transfer the patient from the ICU to a step down, that may change the status. And so I think that part of this problem is that we're talking to IT, and they're talking to us from a HIMSS perspective or a technology perspective. And it's still the delivery of healthcare. Bottom line, it is the delivery of healthcare for patients. And if it becomes so unusable to us as clinicians, then it's going to just be more dysfunctional by the day. So the ITS is trying, they're kind of caught in the middle, trying to make technological solutions for many times where there's no accountability. Worse yet, there's no defined process. I see that all the time, where I ask them for a Visio of the process, and we don't know. Aunt Martha told me to do this 12 years ago. So we had broken processes. Well, it's true. You had broken processes before the EMR came in. The EMR was slammed in, and maybe on quicksand in some places. And these things we fight now and we're struggling with today are really a product of an improper process. There's no documents. I ask for policies and procedures on charge capture. A lot of times I'll get this 1-pager or 2-pager. That doesn't tell me why I have 300 work queues. That doesn't tell me why this system doesn't do this or that doesn't do that. So I think part of the understanding here that would be great for information governance is put those clinical people with those technological people, create a department that can speak the same language. One side's going to have to train the other one. And I frequently see, well, this is an IT problem, or that's usually the answer, or IT needs to fix this for us. We can't do that. And that's usually the response you get when they don't even understand their system to know that they had it in their control all along. So I think this governance, it's essential to move forward at this point, especially with quality measures. We're coming into new platforms of data, new looks of that data. It's got to be in place now.
Yeah. And the trouble is, just like you said, the problem is that the systems are being forced on us, the processes are being put in place, and they never work to begin with because they haven't been used that way before, or the ones that are in place are they weren't designed properly to begin with, and there's no process in place for iterative changes to be made to the process and things. And, people have a tendency to want to just fire and forget. They want to, well, fine, put the EMR in there, and now we don't have to worry about that for next year. Wrong answer. It's something that's got to live and breathe, and it has to change because, in the first place, because it's new. In the second place, because that's how this stuff is happening. It's not a choice. You don't have a choice about this anymore. Not if you want to keep going. Not if you want to keep your doors open.
I saw an article on LinkedIn, Ernie, that says EHR is now up and running, and now I'm done. We're done. We finished it. We succeeded. Well, no, you haven't.
Yeah.
Just
right.
starting.
It's almost like people who think, well, wait a minute, we had all these denials last year. That's why we had a denial group to fix it, a RAC group to go fix it. Why are we still getting denials? They don't understand the process. They really don't. And it's got to be explained to them. Let me go on to a couple more things, and there's plenty about this to talk about. But let me, just another example of something that here, the big changes made with the ACA, okay? Big coverage provisions. I think in that Senate hearing I was just listening to, there are now it's just a lot more, like 14 million more people have coverage now than they did before the ACA. So that's a big deal. A lot more people being covered now have health care coverage. The interesting thing to me was looking at something like this where, I don't know what the CDC has to do with this, but they issued a report, and there's a link to it on the slide, so you can go look at the report. But basically they're saying that adult ED visits since 2013 have remained about the same. I find that, I find that kind of strange. But, there were people who were expecting that there was going to be a lot more, I think, and people who were going to be expecting that there were a lot less. Well, evidently neither one of those things is coming true. Go ahead.
Our later point will come into this. Some of the insured have gone with high deductible plans. So whereby they used to use when they were uninsured, they would go to charity or whatever. They knew they weren't going to get a bill or be responsible for it. Now that they have insurance, they're less likely to use it if they see that they're going to have to pay something. So some of that. Other things is Medicaid is really kind of clamping down and making them go to less costly solutions. So the ED is still, unfortunately, a primary care center for many, many, many people. I don't think that will ever change unless we have 24/7 clinics on site that handle everything. But I do think that many more payers are encouraging their beneficiaries to choose those lower cost alternatives or pay the higher copay or do whatever. So I do think that the number that they expected to jump because of enrollment may have been kind of stabilized by the fact that these payers require a certain venue to receive the treatment, or there's a penalty of some sort, be it monetary or whatever. But I do still see that EDs are a main primary care practice, and I don't see that ever changing.
Right. Yeah, I did find it interesting, and that you make that point. There's that last sentence in what's on the slide there. The portion of uninsured adults who reported using the ED in the past 12 months fell from 8% to 5.9%. So
that's because we have more on insurance. Right.
Well, right. So the ones who are insured, but as you say, it's probably dropping because all of a sudden they've got to pay something, and they're realizing that they'll pay less if they go to the doctor rather than going straight to the ED. So yeah. Okay, let me go to the next. This was a piece of news, and again, I'm just referring. I just pulled these out because these are changes that are happening. The changes keep happening. This is about critical access hospitals. If you're a CAH and you've got to have your documentation requirement, CMS has really restricted how you get that documentation requirement now. AHA is all up in arms about it. I don't know how serious that is, but again, for me, it's just an indication. The changes keep happening. They keep changing little things that may affect you a lot and may not affect you a lot. Seems to me it must affect a lot because otherwise the AHA wouldn't be so concerned about it. So while I'm not familiar with those, it's another example of something that's changing that, seems like, well, why are we doing this?
Well, I mean, the critical access have been somewhat under fire for a while. There was an OIG report, I think about 18, 20 months ago, that the majority of critical access hospitals didn't meet the mileage requirement, and if they had to be reauthorized today, they wouldn't do so. So I think little by little, CMS is trying to focus on the critical access hospitals and see if that's, with all these consolidations, is this, now do I have an integrated delivery network that owns this critical access where we should be expecting a higher level of provision of care? So I think that this is just an ongoing review and really focused review of all things critical access. I don't see this as being different. I see this as being synergistic with everything else that's been going on. AHA has been pushing back every bit of the way. But the critical access. But as we saw with the Affordable Care Act, and we also saw this when we first had those huge bolus of RACs. With 23 rural hospitals went out of business in a matter of a couple months. So I think this is an ongoing stability issue. There are critical accesses that are not in the frontier states. They're questioning that. So I think they're everywhere. They're looking for supervision was an issue with critical access hospitals and the moratorium on looking at them for enforcement. So this has been an ongoing focus. The critical access hospitals really do have their own separate challenges. Yeah,
but it's another indication of the complexity of the system. And how it's not really getting any better. It's still going to remain complex. Here's the latest final rule that CMS just published. Just this past week? Came out on February 12th. It's the final rule about reporting and returning overpayments. Now, the one good thing in it that I think everybody's happy about is they reversed the 10-year look-back period that they had put in the proposed rule, and that's gone back to being a 6-year look-back period, which is, that makes sense, and it's a relief to providers. And it also identifies, again, it goes towards clarifying, identifying, well, what is the knowledge of an overpayment? And so they identify that a little bit clearer. Well, I don't know if it's clearer. At least they identify it. It says that according to the final rule, a person has identified an overpayment when that person has or should have, through the exercise of reasonable diligence, which needs to be defined, determined that the person has received an overpayment and quantified the amount of the overpayment. Now, so you've got to know that you got an overpayment and quantified it. That at that point, then and you are responsible. You got 60 days to report that. So that is, but through the exercise of reasonable diligence, we talked about that a little bit last week. The idea is that you've got to, with whatever CMS considers reasonable diligence, be paying attention to the bills going out the door, and make sure that you're not getting overpaid. So that
and
speaks
as we
again.
Said last week. We
Go
also
ahead.
said last week, too, that you have to really focus on your own backyard. If you're letting claims out the door that may have shown an overpayment and you didn't do your reasonable diligence because you can't extract reports off your system or your system doesn't give you what you need, this predictive analytics and data analytics are quite different. Data analytics is a set of rules and analysis that is done on data now that occurs right now, like the Pepper report, we can look at the denominator and numerator. Those are data analytics. But when we go into predictives, those are usually machine algorithms and things. I think everybody has that obligation now, because that is the reasonable definition almost anymore, because the government's using it. So their statement will be, we're using these techniques and that's reasonable. So I think that will pose a new challenge in courts as to what this reasonableness is. If you own an IT system, reasonably you should be able to extract and have ongoing reporting to ensure that you're in compliance. We all know that some of these IT systems are very difficult to get custom information out of, if at all. So I think this just goes back to this information governance. You know, they should be working with the compliance officer. They need to be working with the privacy officers and start to look at, you know, what information do we need, what information is critical to our core business, and what information is going to support us in our pursuit of clean claims. And I think it just keeps circling the same thing. We're now in a whole new generation, and it's a data-driven generation, and many of these systems for CMS, critical access, and other things, they may have been done in the 1960s or 70s. Everything we're getting now is kind of patchwork. It's your commercial payers that are stepping out of the box with these new risk plans and what have you. So you can't just focus on what you used to do under fee-for-service. You kind of have to put your visionary hat on and say, what is this going to look like in 5 years? What are my challenges? Because I need to start getting that data now. I need to start figuring out now what that challenge is going to be. So a lot of places when I go in and do the dreaded word consulting, I see that, you know, we're kind of chasing our tail with fixing an issue now, but it is for now. But we don't ask the question, in 2 years, is this still going to be valid to the best of our knowledge today? Obviously, Monday morning quarterbacking is great, but to try to put that thought process in and say, does this match our strategic plan? Does this match the government's initiatives? Because the government has kind of shown us a roadmap 3 and 4 years out on where they want to go. They may not go there, but they so we kind of know this. So the information governance is going to just become critical as we move forward.
Right, and I think one of the important things. I'm sorry. Go ahead, Sharon. I'll get in later.
Well, I was just going to piggyback. Yeah, with the definite shift from fee-for-service to quality-based programs, and the potential impact by 2018. I think about 94% of our Part B payment is going to be impacted by the quality shift. So with that impact, you've got to be able to predict from a financial point of view, where are we going to be in the next 3 years and beyond? With the shift to outpatient, with the increased shift to quality, looking at our chronic population, looking at what some of those diagnoses are, and seeing what our financial impact is going to be from a risk-adjusted standpoint.
Right, and that's all things that, I mean, your CFO and your financial people are all going to be trying to figure that out, and they're probably going to come to folks like you to ask, you know, what the heck is going on, and what is the, you know, what's the plan, what's the government, and what are the other payers doing? And so this idea of the exercise of reasonable diligence, well, it's being forced on you anyway. Even though I don't think there's a written description from CMS exactly what that means yet, which, you know, for the lawyers means that there's it can be whatever either side wants it to be, and so then you're going to just wind up arguing about it. But in the meantime, it's being forced on you anyway, because you've got to be able to predict. So you at least know, as Bill and Sharon are both saying, there is a roadmap. Maybe that'll happen and maybe not, but at least there's a published roadmap. We're going to get to more of that in just a minute, because there's this bill that was being considered by the Senate. Oh, and I forgot to take that line off. It says there's going to be more analysis on next week's show. That's not true. That was last week's slide. But this is, you know, this bill is finally being considered by the full Senate, and it has lots of things that could happen. Some that look like they may be good things, and some I don't know how good they are, and I guess we're just going to have to wait and find out. And what happened last week was that the secretary HHS Secretary Sylvia Burwell went in front of the Senate Finance Committee and was talking about it, and she's arguing for having more money and everything so that they can go after their new program integrity investments in FY17. Here are the links to the hearing and the hearing itself, and then the video of the hearing. Now, I was going to try and talk about it a lot, but there really wasn't much said in that hearing itself. They were mostly talking to her about the Zika virus and Puerto Rico and other strange things. So there wasn't much of that. But, so this is kind of back to that slide. But so basically the challenges that are happening are coming because the payers have realized that they can basically take over the revenue cycle process. ICD-10, there's a lot of complexity in that. Is it necessary? Well, I can't answer that, but I know that, like, I went to my doctor recently and I asked him, so how's it going with ICD-10? This is just my primary care guy, and he said, well, it's not that big a deal. There's only about 12 to 20 codes that I use regularly, so there's those. But then I had somebody last week that I had to do some work on one of their fingers, and it was very hard for me to figure out what the heck the code was. There was like 25 codes for that one finger. So it's, and the question is that complexity really necessary? Well, maybe it is, maybe it's not, but it's there whether we like it or not. Then there's the fact that, when I hear this, I see it on Rack Relief all the time. People are saying that, they get a denial for something that was already approved because the payers have figured out that they can deny things, willy-nilly.
And Ernie, I'm going to challenge that just a little bit because I see this every day. And a lot of these approvals that they got were based on a physician CPT code, and they go in and they do something different for whatever reason. And if it isn't urgently coded right after the procedure, recode it, and then you call in the insurance with the new update, they will say that the what you did was different. So there's an issue with, what step in your process are you going to ensure that the payer actually has been updated. And I find that simplest things are wrong. Benefit verification. I mean, there's no Ouija board, but you can look at the beginning of the month, and if they don't have benefits at the beginning of the month, it's unlikely they're going to have them in the middle of the month. So don't schedule those elective surgeries. So we're seeing a lot of benefit verification issues. In last year, one of my clients saw a huge drop-off from people that stopped paying their premiums once they got their tax return back. So they stopped their premiums. They stopped getting coverage for several months, and so they fell off the grid. But yet the payer still listed them in a phrase called pending status, but they didn't describe pending status meant that any auth you got was not going to work. So I think there's a lot of, you have to look really, really closely when they say the auth failed. What about the auth failed? What exactly happened here? And you're going to have to do that nitty-gritty. And I'm seeing hospitals spend enormous amount of time on denials management and looking at what was that root cause. What are those patterns of behavior? Is it as simple as adding another FTE on 3 to 11? Many of these insurance companies, especially where I am in the Southeast, they close at 5 o'clock. But in the Northeast, they were much more electronic access, and they had much longer hours. So, getting with those contracts and saying, you know what, if you're going to make me get an auth and you're going to make me sit on the phone for 2 hours because you're so busy, because you have a short day, then when we contract with you, you're going to have to lengthen your day for us because we need to be able to get the auths. A lot of auths are never completed because you can't get through and complete with the insurance company. So there's a lot of these when it says approvals are no longer meaningful. I agree with that. But what I'm not sure about is what about it wasn't meaningful and how can I fix it? Is it in my control? That's the key question. Was there something in my control?
Well, I start to feel, though, like, from a layman's point of view, and I'm sure that I'm I'm at least somewhat off base, and it really doesn't apply because we're talking about health care. But, when I take my car into the mechanic, and, they're going to work on it, they come back to me with an estimate, and, they say, this is what we should probably do. These are your options or whatever, and I give them approval for it. And it's not necessarily going to be exactly that later. It may be that it changes later. He gets into it and finds out, oh, you know what, we also needed to replace this. Now, sometimes they talk to me about it, and sometimes they don't. If I trust the guy, I just tell them, look, go fix it. But, in the case of this, they're going before the payer and saying it's this, and if it turns out to be something different, I don't think the payer should be able to say, well, no, just no. I think there ought to be some kind of there ought to be some kind of a conversation that happens, and it shouldn't be that you're going to get nothing because you didn't do exactly what you said you were going to do, so we're going to cancel the off. That's just my opinion.
The difference there, Ernie, is that that mechanic calls you and says this is the problem. Do you still want me to do it? And then you have a choice of whether to do it or not. When you're in there with a patient and you're doing surgery, you're going to do it then.
Yeah.
Yeah.
There's no chance for you to go back and say, you know what, we had to change this. There was a medical reason. So it's, I don't think the payer should be able to just say, no, we're not going to pay you now. Somebody was asking
the other
about,
thing that we're seeing a lot of is the patient's in the appropriate inpatient status, but now the payers say, oh, well, the procedures you do during that inpatient status, they need separate auth. So the MRI you just did, you'll need an auth on that. So they're really, really coming back with that craziness. And so you're going to have to really work diligently, and every revenue integrity team has to be connected at the hip with managed care contracting. You have to be there. Here's what we're seeing. Here's the denial. I need you to go. There are 3 of these. They're not right. I need you to be working with our payer. And a lot of that can be resolved. There are payers out there that I believe Harry Potter could come with the wand and we will not fix. They're just going to deny, okay? But for some payers, you can make some headway. But some of these things I see on rack relief and everything that make absolutely no sense, when it's so crazy, likely it's because the payer has some sort of scheme. Or they don't even know. But there are things that you can take up with the payer and be very successful. And these approvals really are those. Put in your contracts. What are the approvals you're going to get? What are my carve-out approvals? Start to focus on this approval process. It becomes much more important as you move forward in these risk-based models because some of this stuff becomes more risk.
Let me say this really quickly, Bill, just to jump on that contracting piece, and then you're talking about that risk-based piece. I have a colleague of mine that called me, and she's the chair, and everyone's talking about this risk adjustment stuff and HCC coding, and, I don't understand it and what's happening. How is this impacting me? She actually works with Part B, and I said, okay, you need to get with your contracting department and find out if you have any risk-based plans or incentive-based quality plans. Well, she comes to find out they have incentives written into some of their managed care contracts that they knew nothing about, that they are getting paid for the member or the patient an additional amount of money if they're meeting a certain risk adjustment score. Well, guess what? They didn't know that. So there they are in this incentive program and not getting any money from it because it was never communicated to the right people that they needed to address this. So once again, I think we have lots of people in the audience where all these things are happening around us, but the communication isn't getting to us. So there is opportunity for payment impact at your facility that you might not be aware of. And you really need to get with your contracting and ask these questions. And as Bill was saying, have good relationships so you can get a better handle on some of the problems that are related to the other aspects of process.
Right. And one of the, I'm going to
just,
yeah, go ahead.
Stephanie's just written that operations and clinics are rarely invited to participate in the discussions. I totally agree with that, and that's why you have to just be a nuisance, and you just have to invite yourself to the party. Every place I've worked, managed care has kind of been taboo. You can't go there. They're doing their thing. You're not supposed to know.
Nope.
I have, when I've been successful, I've just invited myself to the party and been a complete and total burden on them. I've done that. I'm like, guys, you've got to tell me because I can't fix this unless we know. So we've kind of gotten them now to the point where they do take a Xanax when they see me, but they know now that I'm trying to help.
Yeah.
Well, and I showed my value in the conversation to help them better negotiate a contract. So once you can get that ear and once you can understand it enough to show how what your knowledge is going to impact the decision making for that contract, it's going to pay off. So you just got to get in there. And I know exactly what you're talking about, Stephanie. You know, tackled that about 10, 15 years ago, and it continues to happen. But you got to get in those conversations. Right.
And let's talk about we're getting down to the end of the show. I wanted to make sure we get to this one slide I had about high deductible plans and how that's becoming an almost impossible task these days. Bill, you and I were talking about this yesterday.
Let's talk about some of the high deductible issues, okay? One, they're more affordable, so people have been driven to this. Number two, those surgeries that they used to get that they didn't think twice about, they may now postpone them. Elective procedures they may postpone because their deductible's so high, so they're going to wait until there's another illness to book it on top of. We're seeing that the high deductible plans, even if they do come in and need something, then they can't pay their co-pays or deductibles because it's so high. It's more than they have, and it's more difficult than ever to really get people on a payment plan because some of the plans actually have restrictions on balance billing. So, I mean, there's just all these new and novel concerns. Yes, there are more Americans being insured, but is the insurance just a catastrophic level? Is it a high deductible, or is it traditional? I think one of the issues that we're starting to see that people are starting to look at is your payer mix by plan type, because that's going to show you where you're moving and where your obstacles may be. So I think this should be something that we should keep in our radar because as risk moves and high deductible moves, it's going to cause a difference in our patterns of behavior. I mean, ultimately, the insurance company manages risk, except for in the state of North Carolina where they said they're not going to do that anymore and that the hospitals are going to manage the risk. But the insurance companies manage the risk. And when they do that, it's for profit. They're not there to lose money. So therefore, they may give you a lower premium, but that means you're going to have to pay on the back end. It's either pay me now or pay me later. So I think when you look at these high deductibles, one is you have to educate your consumers if you're got a network type thing. And number two, you need to educate your staff. What are those obstacles going to be? If you have a high deductible person coming in for an MRI and they look like they're on a fixed income but not yet Medicare, or they have one of these, you may have to talk to them right then and there about that payment plan that they're going to have to go into so that they know what they can expect. So I think we used to ask for copay and deductible, and they were amounts that I think people could swallow. But now you're going to be asking for $5,000. And that's a whole different culture. Physicians aren't going to want their patients ask for that high deductible at once. Once they're out the door, you know, if you bill them, the collectability is quite a bit smaller. More goes to bad debt. People are starting looking now when they do procedures, the propensity to pay. So there's all these new things that are coming around the ACO, especially with propensity to pay. and looking at what are these plans really doing. So it would behoove you to look into some of these plans and some of the patterns that occur in your facilities.
Right. There's a challenge in that, because it's like, you need to see historic data, you need to know something about the patient, you need to understand the payer's rules and have something that says, whether or not you can, what the copay is now for this patient today to do this, and then you need to also know what are your plans for helping the patient with this if it's not something that they can just swallow right away. And also, I think
you need to do that with 3 less FTEs.
Right, yeah. As if that's even possible. This is the part that I think is the most difficult, is because there's never been an integrated system to do that. The ones that are coming out are, perhaps too expensive, or, just doing it manually may be either impossible or hugely expensive. But it's something that needs to happen, because otherwise, that's mission critical. Can you collect that deductible or not? Well, if you can't collect deductibles, that's an awful lot of income that's going to go out the door, or it's going to wind up in bad debt. It's mission critical. So PFS has to be able to do this, and I know they're used to doing some of it, but it's just not. It's not something that's natural. It's not something that's very well integrated yet. But your patients will like it, because if you can at least tell them now, instead of they get bills 2 months or 6 months later, that are much higher than they ever expected them to be. So it makes a lot of sense to try and figure this out. We're going to try and find, some solutions about that and talk about, how to try and do that. If any of you on the phone today have, processes where you are doing this kind of integration, I would love to hear about it. I'd love to talk with you about it. Don't have to share who you are, your facility, or anything if you can't do that or don't want to do that. But that is something that we definitely would like to hear about, because that's a big deal. We'd like to be able to talk about pointing in the direction of those solutions. The other thing that go ahead, Sharon.
I see Dr. Meyerson's on the phone today. I know we're about to wrap up, but I didn't know if maybe he might have a comment about anything we talked about today.
Is Steve on? I didn't see him on the list. Well, I don't know if he's on or not.
I don't see Dr. Meyerson unless he's a viewer number.
Yeah.
Okay, I saw him earlier. He might have popped off.
Okay. Somebody saying, Bill saying, yeah, maybe get these guys to donate to Kanye West. Yeah, the CEOs are just making too much. I don't get that. CEOs that make $1 million a month or more. I just don't get that. I'm a Republican. I don't get that. Or I've been a Republican in the past, I should probably say. I can't say
that's quite the end. So let's wrap it up. It's 2:00.
Yeah. Okay. Well, anyway. Okay. So coming up. One more comment I just had to make was the previous slide. I got to get this dig in. It's the provider education that's coming out of these payers. This is the CMS example of how they explain, how they educate. They give great education according to what they report to Congress. This is basically what they do. They give us the problem and then they point at it. They read the regulations. They don't really tell us how to do it. And that's just not that's not an answer. That's not an explanation. They can't explain them because they don't understand them either. They've got so many people putting them together. They can't even explain the implications of them and everything. So anyway, okay. Well, that's all we got time for today. Coming up in a couple of weeks, March 4, we are going to point you at at least one tool that will let you see at least some of your data, like CMS does, and actually we'll talk about how you can do that with or without a tool like this. But the best thing is, again, going back to predictive analytics. To be able to have something that has algorithms built into it, that's the best way to do it. But we'll talk about that on March 4th. And then we're still working on, because everybody's busy and these aren't exactly simple topics, how to show ROI for physician advisors and rounding and denial management departments and things like that. And also, we're going to talk about tactics you can use to fight payer contracts, and I'm working on that by talking to several people as well. Right, yeah, Stephanie's saying, yeah, regs are like that. Regs tell what to do but not how to do it. Yeah, well, I don't think that's enough. Well, I'm sure everybody agrees with me. It's just not enough. So, but that's what we wind up with. So, okay, so that's all we have time for this week. And we will be back live next Friday, February 26th. Don't know what we'll be talking about yet, but we'll figure out something. Thanks to everybody for being with us today. Special thanks to everybody in the chat box, and also to, of course, Bill and Sharon, who are always here and able to give us great insights and help. And, of course, I want to thank our sponsors, the Health Law Partners, MedLinks Cost Containment, Aerolib Healthcare Solutions, Recovery Analytics, and the CCMA. And remember, folks, it is their contributions that make these broadcasts possible, so please be grateful to them. Watch for my emails about next week's show on February 19th, and please share the links to our show with your colleagues and friends. And the last thing I want to share with you is something from not exactly one of my, I'm not a great admirer of the fellow himself, but what he did and what he stood for, I completely agreed with. And, Steve Jobs, you can see it in Apple. He said that was one of his mantras. Focus and simplicity. Simple can be harder than complex. You have to work hard to get your thinking clean and make it simple, but it's worth it in the end, because once you get there, you can move mountains. That's what we want, folks, is simplicity. Keep trying to simplify things at your place. So anyway, thanks very much. We'll see you next time, everyone, when it's finally Friday. Have a great weekend. Bye-bye. I keep telling you guys to stick around. I keep forgetting to telling you guys to stick around. So anyway, call everybody in a minute.